We're here today with Dr. Yuan Luo, the Chief Artificial Intelligence Officer of Northwestern University Clinical and Translational Sciences Institute. Dr. Luo is also an associate professor at Northwestern University Feinberg School of Medicine and is an expert in multimodal AI ML for healthcare. Yuan, thank you so much for joining us today.
Thank you, Jordan, for having me.
Yes. There's a lot of topics I'd like to cover today. You've been publishing in peer academic reviewed medical journals. The first topic I'd like to discuss is a topic of disparities in machine learning algorithms. According to some research you've recently published in Circulation Heart Failure, integrating social determinants of health into machine learning models has helped mitigate bias when predicting long-term outcomes for heart failure patients. And at the best performing model, initially underdiagnosed several underserved patient populations, including female, Black, and socioeconomic disadvantaged patients. Yuan, would you please tell me more about this study, its purpose, and its conclusions?
Certainly. So this is a very interesting study. And initially, we observed that there's a lot of disparity in terms of applying machine learning models to different groups of the patients, and especially for minorities. And contrary to the conventional wisdom that when you want to improve on the fairness of the algorithm, sometimes you need to trade off between the egalitarian perspective and the utilitarian perspective, meaning that you probably want to trade off the overall accuracy for the equity. But what we have found is that by integrating social determinants of the health together with clinical data, we were actually able to improve both the equity and the utility, the accuracy of the algorithm at the same time. And so this is very encouraging in that we don't really need to trade off one versus the other, but we can simultaneously improve both of them.
I see. And so I know you also have so I want to stay on this topic, but I want to mention that you're also involved with translational applications in medical research. So here you are, you've arrived at this new insight that you can integrate SES and clinical data, you can improve accuracy and fairness at the same time. Now that you've learned that, you've developed these multivariable linear regressions, you can account for disparities. How do you translate that into clinical outcomes and practice at Northwestern Medicine?
Right, so translation is always very important and high on the priority list for the team that I lead. And translation also needs the support and also, frankly, the enthusiasm from the clinical champions. So for example, in one study, we were working with cardiology specialists on heart failure patients. One of the unmet need in the primary care setting is that a lot of the patients, they were transitioning into advanced stage heart failure without being noticed by the primary care physician. This is the unmet need. We recognize it, and we develop the machine learning models to predict who is going to transition into advanced stage heart failure based on their past medical history and also the clinical record that we have. And when we predict someone is really having a higher risk, we alert the primary care physicians and refer the patients to the cardiology specialist for evaluation and for interventions. And for some of those patients, we actually got left ventricular assisted device planted in their heart and to reverse or slow the clinical course for the advanced stage heart failure. And this is deployed in the health system, and we have strong support from our clinical champions in cardiology. And this really strengthens not only the methodology building, but also in terms of the implementation and the deployment of the model. And we really also learn a lot throughout the course into how to best deploy the model into the clinical setting and how to best work with not only clinicians, but also nurses and patients themselves.
So, Luan, you said that you alerted PCPs about patients who are high risk to refer them to cardiology specialists and interventions. I wonder if you compared outcomes during a time period of your application of this new best practice advisory to a baseline of prior to this intervention to see if there actually were any improvements kind of at a subpopulation level in outcomes.
Right, we actually compared the differences, and we had a publication in one of the clinical journals. And most importantly, for those patients that would not be referred unless we have the system, some of the patients actually get left ventricular assisted device actually planted in their heart.
Sorry, what was the outcome with those patients?
For some of those patients, they actually got left ventricular assisted device planted in their heart.
Oh, wow.
Yeah.
So it led to an actual cardiac intervention that may have prevented a heart attack.
Yes.
Well, that's, I guess, the ideal outcome for our listeners. I think that's an interesting takeaway. I'd like to transition to the next topic. You're involved in the Institute for Augmented Intelligence in Medicine, which has established a Center for Collaborative AI in Healthcare with the mission of advancing artificial intelligence, science, engineering, and translation throughout healthcare specialties to create a positive impact on precision medicine. Tell me about this institute. Some of our listeners may be thinking, well, we have some sort of ML algorithms deployed within our EHR. What's the benefit of establishing an institute?
Right. So this was actually stemmed from our observation and also, frankly, some of the pain points that we have lived through when bringing collaborations between the AI ML scientists and the clinicians. So you have probably heard that some of the AI proponents said multiple times that AI is going to replace pathologists, AI is going to replace radiologists, and of course, none of this has come true. And on the other hand, the pandemic has really been a bubble burst moment for some of the AI machine learning models. And especially, there was a paper that reviewed hundreds of prognosis and diagnosis systems using imaging for COVID-19 outcomes. And virtually none of those were actually deployed into widespread clinical use. That has led to the sort of bubble burst moment, and some of the physicians were suspicious, or some of them may even have cynicism towards the AI system. So, contrary to what we had hoped for, there might be barriers in terms of the collaboration between physicians and the AI machine learning scientists. What we have observed, what works best is to engage the physicians and AI/ML scientists from the beginning and guide them through this end-to-end journey from the model inception to the model development, deployment, and actual use in clinical settings. This is why we have launched an initiative called AI for Health Clinics. This clinic is open to all the practicing physicians in the Northwestern medicine health system, and they can come in and pitch their clinical challenge, and the staff and AI machine learning scientists and even the trainees who are very interested can help them brainstorm the solutions, debate on the implementations, and iterate on those implementations and actually help them deploy it after the implementation to the health system. And this has been going on for multiple years and received wide accolade from the clinical system, and led to multiple federally sponsored grants and also deployments of the system into health system, and also in terms of really generating tremendous opportunity for education because we actually taking trainees to work on those projects. And this was sort of the prototype for the Center of Collaborative AI in Healthcare. And once we realized the benefits and the interest from both the health system and also the medical school and the engineering campus, we wanted to formalize and streamline the process which led to the birth of this center. And the mission of the center is to bring the communities of AI, ML scientists, the engineers, and the clinicians into this fertile ground so that they can cross-pollinate each other and invite each other's perspective to add on to their own. And most importantly, collaborate with each other from beginning to end of the developing and deploying the machine learning models into a concrete healthcare challenge.
Excellent. I think that's interesting. You're deploying models to bridge silos within different disciplines that are associated with the delivery of healthcare at Northwestern. You also have so on a topic of connecting different bridging silos and connecting different departments, you've also been connecting different institutions to build a flagship data set for healthcare AI. There's a project you're involved with that involves Northwestern University, the Massachusetts Institute of Technology, and multiple clinical translational science award hubs at CTSA, including those at Tufts University, Washington University, and the University of Alabama at Birmingham, in order to create a flagship data set that's large enough and diverse enough to capture all aspects of patient profiles before and after their intensive care unit stay. And what makes the data sets useful is to train a model to predict a patient outcome or train a model to recognize certain less frequent diseases. Can you tell me about the impact that this collaboration has had on patients at Northwestern and elsewhere?
Yes, and this is really meant to address the gap that we observed between general domain machine learning, which you saw have tremendous progress since the last decade, versus the healthcare field, which seems to be lagging behind the general domain. And we were analyzing the differences of why there is such a gap. And we realized that in general domain machine learning, you really have this flagship data sets that is large, that is publicly shared with the research community, so they can constantly benchmarking and improve on these status state-of-the-art methods. But in healthcare field, we do not have the counterpart of ImageNet or the Wikipedia corpus, at least not yet, that is very diverse and also that is very large, that is publicly shared. And so this is why we set out to launch the mission of creating such a flagship data set and really hope that this could trigger a wave of similar efforts and initiatives across the nation. And the idea is by pulling together the patient cohorts from a diverse geographic locations from the Midwest to the East to the South, we can capture the geographic diversity, the racial ethnic diversity, and also the practice diversity. So for example, a procedure such as bronchoalveolar lavage that is routinely practiced in Northwestern's ICU for pneumocritical care may not be the routine practice in another institution. And we want to capture such practice divergence. And that will lend the spectrum of the data to cover a great deal of diversity. And this is why we were inviting so many academic medical centers to join the efforts to pull together their data. And when we have the data from their critical care cohorts, we want to capture everything, not only just their critical care states, but also things leads up to it, the encounters before the critical care state, and also what happened after the encounters after the critical care state. By capturing such a comprehensive and longitudinal profile of the patients, we really hope that this could provide this flagship data set to power the next generation of machine learning development. And we want to share the data with the entire research community so that people could benchmark on this data set and use this data set to identify novel hypotheses and also validate those hypotheses and generate insights from the data, insights that relate to real world evidence that you could use to power the pharmaceutical and therapeutical development and even drug repurposing. So all those kind of downstream applications would be very natural consequences of such flagship data sets.
Was there, so on the topic of generating large data sets, you also have been, I mean, that's the purpose of developing large data sets is to support research, is to
Yes.
lead to new developments, like you said, to identify and validate novel hypotheses and generate new insights that may benefit patient outcomes and enhance the delivery of care. You also have been involved in the creation of something called a spatial transcriptomics analysis resource. The acronym would be SOAR, and it's used
Yes.
to evaluate spatial variability of genes in different tissues to assess possible cell-cell interactions and visualize the spatial gene expression of 1,700 samples. This is also is receiving publicly I think NIH funding for the grant, but it's meant to benefit research across the United States. So, can you tell me a bit about the SOAR program and what your ambitions are there?
Right. So that's a great question. When we are working on clinical data, we realize that often you need other types of data to complement it. So clinical data tells you about the patient's journey and their clinical progression. On the other hand, we also need deeper understanding of the disease mechanism. And the molecular data, such as those provided by the emerging technology of spatial transcriptomics, can offer you that. And this is a really interesting technique in that it does not only give you the single cell level RNA expression, it also tells you where such expression patterns happens in what part of the tissue. So let's say if you want to understand the interactions between CD4 and CD8 T cells and the malignant cells, and when they are closer, how their expression profiles will change. When they are farther away, how their expression profiles will change. The spatial transcriptomics technology can tell you that. The issue with the current status of that field is, although there are many papers published, they each gone through different quality improvement, quality checking process, and batch effect removal, and there is little consistent consensus standards that the different papers use to process their data, making the meta-analysis and mega-analysis reusing those data really difficult. So what we set out to do is we took all the data set that's published in mainstream journals and we consistently process them so that they are subject to the same quality checking standards, the same batch effect removal standard, consistent standards, and we perform dimension reductions to get rid of some of those artifacts. And also we perform cell type annotations so that you know what cell types have this or that kind of spatially variable gene expressions and how different cell types can interact with each other. By doing that, we really enable the meta-analysis and mega-analysis for reusing this public trove of the resource. Because if you think about it, when people publish papers, they often publish on the strongest signals from their data. That doesn't mean their data cannot support additional hypotheses, additional findings, just mean that sometimes they may lack the enough samples to do so, or maybe the signal isn't the strongest. But if you pull together all those published data, that will give you an opportunity to generate new hypothesis that is impactful, that gives you new insights on this disease mechanism. And when you combine those understandings to what you observe from the clinical side on the patients, you can really triangulate different sources of evidence to look at complex disease and also to inform targeted therapies.
So, Yuan, we are approaching the end of this podcast episode. And when I look back over the topics we've covered, from socioeconomic disparities being addressed by machine learning algorithms, we spoke about crossing different departments and integrating engineers, clinicians, and AI scientists together in order to collaborate in a unified mission. We spoke about building flagship data sets for across different healthcare organizations and also taking published research on a cell level and making it available for different purposes to be applied to different hypotheses. It almost seems as though there's a common theme of altruism, where most guests on public and Healthy Data podcasts speak about how their efforts are translating into improving lives for patients, sometimes improving the delivery of care. But it's interesting that you seem to be improving things for researchers, creating a foundation upon which they can do their work to more directly address the patients. Would you spend the last remaining moments of this episode speaking about kind of what your purpose is, what your motivations are, what you're looking to accomplish, and how you see your role within the healthcare delivery system?
Right, Jordan, that's a great point. And so how I see my role in the health system is I see multiple aspects that I could contribute. So first of all, I could contribute as the hub of the AI expertise to support different specialties, whether it's clinical or whether it's basic science. They could all leverage on the AI and machine learning toolings and resources that we have built. And we are very happy to support them because ultimately, whether it is an advancement in terms of the basic science or basic biology, or whether it's advancement in terms of the clinical practice, they eventually will benefit the patients like you and me. And so this kind of altruism notion is really deeply embedded in the team that I lead and in the colleagues that I worked with at Northwestern, because we share a common goal. And a lot of the times we share our data set, we share our toolings, and then we make them consistently available to the researchers not only in the Northwestern University, but also across the nation so that people can benefit from that. And I frankly think this kind of sharing and altruism can rapidly and accelerate the advancement pace of the technology. Because if you think about what happens in the general domain machine learning and AI development, a lot of the times it's because we have this foundations of the data set, the foundations of the tooling that we share across the community, that really drives the state-of-the-art advancement. And similar things can happen here, and especially based on our experiences of creating the Center for Collaborative AI for Healthcare, we think that people, when they share the same mission, they can easily be brought together to this fertile ground to work on their aligned goals and to collectively drive the field forward.
Well, thank you, Yuan. For our listeners, this has been Dr. Yuan Luo, the Chief AI Officer of Northwestern University Clinical and Translational Sciences Institute, and an Associate Professor at their School of Medicine. Yuan, thank you so much for joining us today.
Thank you, Jordan, for having me.